the prevalence of GDM is found to be points varying from 0.7 to 10.1%. The early detection of GDM is very important for reducing adverse pregnancy outcomes. Why is there the necessity to screen for GDM? Because there are two generations at risk, the mother and the offspring. We have, according to a study published in the American Journal of Obstetrics and Gynae 2009, it was found that 50% of women who had gestational diabetes mellitus developed type 2 diabetes mellitus after 20 years of the pregnancy. The treatment of GDM also decreases perinatal morbidity, and hence the treatment of even mild GDM is very beneficial. I'll be commenting on the different types of diagnostic criteria proposed by the different groups. First, there is the criteria given by WHO 2013. It states that hyperglycemia at pregnancy can be divided into two groups. First is the diabetes in pregnancy, and the second one is gestational diabetes mellitus. Diabetes in pregnancy is diagnosed if any one or more of the following criteria are met. That is a fasting more than equal to 126, a 2-hour more than equal to 200, and a random blood sugar of more than equal to 200 milligram per deciliter. If GDM is to be diagnosed, then any one or more of the following criteria are to be met: a fasting blood sugar of more than equal to 92, a 1 hour of more than equal to 180, and a 2 hour of more than equal to 153 milligram per deciliter. This shows the IADPSG two-phase strategy for the diagnosis of gestational diabetes mellitus. Any woman who comes for the first antenatal visit is advised a fasting blood sugar and a ppbs. Overt diabetes is diagnosed if the fasting is more than equal to 126 and HbA1c is more than equal to 6.5, or the random blood sugar is more than equal to 200. Gestational diabetes mellitus at first visit is diagnosed if the fasting blood sugar is more than 92 but less than 126. If the fasting blood sugar at first visit is normal, then we go to the second stage, that is the 24-28 weeks oral glucose tolerance test using 75 gram glucose. It states that if any one of the following values are deranged, like fasting 1 hour or 2 hour, which I have already mentioned in the previous slide, then the patient is diagnosed to have gestational diabetes mellitus. This shows the NICE 2015 guidelines. It states that women who have a history of GDM in the previous pregnancy should be screened with an oral glucose tolerance test at the very first visit. But if the patient is not having any history of GDM but has any of the following high-risk factors, then the patient should be screened for oral glucose tolerance test at 24 to 28 weeks period of gestation. And it states that if after this study the fasting is more than equal to 100 or the 2 hours is more than equal to 140, then a diagnosis of gestational diabetes mellitus is made. This shows the ADA 2016 criteria for diagnosing gestational diabetes mellitus. It states that if the patient is at high risk, which is the above conditions, a BMI more than 25, a first degree relative with diabetes, hypertension, women with PCOS, then she should be screened with OGTT at the very first visit, and if not, then 24 to 28 weeks is the ideal time for GTT. There are two procedures. We can either do a one-step procedure or we can do a two-step procedure. The one-step procedure involves OGTT directly. The two-step involves a 50 gram glucose challenge test irrespective of last meal, and if the 1 hour value is more than 140, then we do a GTT. But the diagnostic criteria for GDM here differs. It is according to the Carpenter-Kuster criteria, and the values are slightly different. ACOG 2013 recommends that all pregnant women should be screened for gestational diabetes mellitus, and the two-step screening strategy is to be adopted for diagnosis, not the one-step screening strategy. DIPSI is the Diabetes in Pregnancy Study Group India. It has given a universal screening procedure for the diagnosis of gestational diabetes mellitus. It is a single-step procedure, and the patient is given a 75 gram glucose load irrespective of the last meal. If after 2 hours the patient has more than 200 milligram per deciliter fasting, she's diagnosed to have diabetes. If more than 140, she's diagnosed to have GDM, and if it is more than 120, she's supposed to have decreased gestational glucose tolerance. This is the AIMS protocol, in which at a first antenatal visit, in no high risk groups, we do a fasting blood sugar and ppbs, and if at a high risk, we directly go to the phase 2 of the IADPSG criteria. I'll currently be presenting the AIMS data. All the patients who had the pregnancy with diabetes were evaluated in the time duration of January 2011 to December 2015 and who presented to Gynae Unit 1 AIMS. This shows the patient profile, and we have found that around 35.8% of the patients were in the age group of more than 30 years and 19.2% of the patients had a BMI of more than 30, which are the risk factors for gestational diabetes mellitus. And around 58.5% of them belonged to middle socioeconomic class. In our study, the prevalence of diabetes has come out to be 6.5%. This shows the distribution of the different types of diabetes in the study cohort. We had one patient with type 1 diabetes, 22 with type 2 diabetes, which accounted for 11%, and 88% of our study cohort had gestational diabetes mellitus. This shows the comparison of the baseline characteristics for the study cohort. We have found that the mean age we have divided the data into two groups. The first group is one including type 1 and type 2 diabetes mellitus, and the second groups include all the patients with gestational diabetes mellitus. So we found out that between the two groups, the age and the gestational age at delivery was found to be significantly different. It was lower for the first group and the age factor was higher. This slide shows the obstetric history and what are the relevant factors in the past history which were present in the different patients. Around 8.3% of our patients had a history of gestational diabetes mellitus in the previous pregnancy, and 35% of them had a history of prior abortion. History of macrosomia in the previous pregnancy was present in around 4.7% of the patients, and 6.2% of the patients previously had congenitally malformed babies. This table shows the comparison of the obstetric history between the two groups which I mentioned before. The first group showed that our evaluation showed that the comparison of the history of IUD and history of macrosomia abortion was not different between the two groups. This shows the risk factors for diabetes, and we have found out that patients who had type 1 and type 2 diabetes had a significantly higher family history of diabetes mellitus as compared to patients who had gestational diabetes mellitus. The p-value was found to be significant. These are the investigations at admissions of the patient, and we had fetal echo available for 24 patients, and out of them only 2 were found to be abnormal, and the dual marker and triple marker were found to be abnormal for around 8 patients out of the 193 examined, and 5 opted for invasive testing, and out of the 3 who did not opt, 1 had a baby with Down syndrome. This diagram shows the pattern of the HbA1c levels in the study cohort. The HbA1c of more than 6.5% was found in 19.2% of the study population. This table shows the level 2 ultrasound reports of the different patients. We found that it was abnormal in just 4% of the cases, and the abnormalities found were echogenic cardiac foci, choroid plexuses, gross ventriculomegaly, bilateral dysplastic kidneys, and ascites. This is showing the evaluation of fundus for the different patients. We had fundus findings for 105 patients, and out of them, only 4 were found to be abnormal, 3 with a non-proliferative diabetic retinopathy and 1 with a proliferative diabetic retinopathy. This is the therapeutic approach adopted during pregnancy by an institution. We adopted medical nutrition therapy for around 71% of the patient, and insulin and diabetic diet was given to 18.6% of the patients, and 8.8% of the patients were managed with oral hypoglycemic agents and diabetic diet. There was just one patient who required all the 3 insulin, OHS, and nutrition therapy. 2 patients, one each of type 1 and type 2 diabetes, required insulin infusion in the pregnancy. According to the study, type 1 and type 2 diabetic patients had more rates of hospitalization prior to delivery, and this was found to be significantly higher as compared to the GDM group. This is a diagram which shows the different gestational age at delivery for the patient. We found that most of the patients, around 83% of the patients, had a gestation age at delivery of around 37 to 40 weeks. The main mode of delivery in the patients was a cesarean section, and 42% of the patients had a normal vaginal delivery, and instrumental delivery was present in around 5% of the patients. This table shows the comparison of the mode of delivery between the two groups, first being type 1 and 2 and the second group being GDM. We found that there was no difference in the mode of delivery between the two groups, whether it may be vaginal or a cesarean delivery. This shows the different indications for cesarean section in the patients. We found that 15 out of the total cesarean deliveries, 15% of the patients had a cesarean section for fetal bradycardia, and 15% of the patients had cesarean for meconium stained lichen, which were the two prominent indications for cesarean in diabetic patients. This table shows the comparison of maternal characteristics. It shows that 5% and 4.5% of the patients had a history of UTI. Chronic hypertension developed in 7.2% of the patients. 14% of the patients had gestational hypertension or preeclampsia. Polyhydramnios was found in 1.5. A stillbirth or IUD was present in 2.5% of the patients. A significant percent of our patients developed intrahepatic cholestasis of pregnancy, which was 17.1%. The one significant finding which we found was a difference in the preterm delivery rates between the two groups. This is the table comparing the maternal complications in the postpartum period, which were like wound gape, postpartum hemorrhage, requirement of insulin at the time of discharge, and the manual removal of placenta. We found that more patients in the type 1 and type 2 diabetic group were discharged on insulin as compared to the gestational diabetes group. Out of the 200 babies, which included 7 pairs of twins, we found that the large for date babies, the percentage was 25%, and macrosomia was present in 3% of the babies, congenital malformation in 6%, IUGR in 3%, and the stillbirth rate was 2.5%. Shoulder dystocia was 1.5%. These were the congenital malformations found in the babies, out of which the major ones were Down syndrome, hydrocephalus, and congenital diaphragmatic hernia, meningocele, and a hypoplastic left heart. This table shows the mean birth weight in all three categories of diabetes. Gestational diabetes, the mean birth weight was 2.845 grams. In type 1, the weight was low, 1.5 kg. The mother delivered preterm because of other problems. And in type 2, the mean birth weight was 2.5 kg. This is a comparison of the neonatal outcomes in the terms of the weight of the babies. We found out that out of the 25% of large for date babies, most of the large for date babies were found in the gestational diabetic group, and 8.6% only were found in the type 1 and type 2 group. These are the complications which develop in babies with diabetic mothers. One was a term neonate with respiratory distress syndrome, hypoglycemia, hyperbilirubinemia, neurological deficit, and neonatal death. We found that the babies of type 1 and type 2 diabetic mothers developed more hyperbilirubinemia as compared to babies of mothers with gestational diabetes, and this difference was found to be significant. We followed 155 patients who had gestational diabetes mellitus at the end of 6 weeks, and we found that 9% of them had deranged glucose tolerance test. I will now request Dr. Venus to come and discuss the review of literature. Thank you.
A very good evening to all. According to WHO 2016, India has 70 million people with diabetes, and prevalence of GDM varies from 4% to 21% in different parts of India. Prevalence is increasing because of increasing urbanization, decreased physical activity, change in dietary patterns, and increasing obesity. This is a study by Garigueta et al. Published in 2014, according to which the crude prevalence of GDM in India was found to be 25%. Now, this is the study done in Tertiary Care Center in Haryana, which found a very low prevalence of 7.1%, which was similar to our study, and the baseline characteristics were also similar. For at least a generation, there has been a divergence of opinion about GDM screening. Most convincing study on adverse outcome was the HAPO study, which was published in 2008 in NEJM, and which included 25,000 women in 9 countries, and they underwent 75 gram GTT at 24 to 32 weeks period of gestation. And the patient who had fasting of more than 105 and 2-hour value of more than 200 were excluded, and the results of fasting 1 hour and 2 hour were stratified according to the categories, and neonatal and maternal outcome were assessed, and it was found that comparing the lowest versus the highest fasting blood sugar category in the mild GDM, it was found that even in the lowest category, there was a significant maternal and perinatal adverse outcome, and it increased, the adverse outcome increased with the increase in the fasting blood sugar. And similar results were found in the 1 hour and the 2 hour group. With each standard deviation increase in fasting blood sugar, there was 21% increase in preeclampsia and 18% increase in shoulder dystocia. This is the another study which supports HAPO, and it shows that even treating the mild GDM will lead to a better maternal and perinatal outcome. Similarly, this is the study in 1800 women which shows that continuous relationship exists between the maternal glucose levels and perinatal morbidity. So there is no obvious threshold at which risk increases. After the HAPO study, IDPSG developed revised recommendation for the diagnosis of GDM. But the problem in the Indian setting is if the patient are asked to come on another day in fasting state, many of them will not return. So the solution was DIPSI criteria. This was a study by Anjalakshmi et al. In which the 800 women who underwent DIPSI, GTT with DIPSI criteria and with the WHO criteria, equal number of GDM patients were detected. So which made sensitivity or specificity of DIPSI criteria to be 100%. And DIPSI criteria is a patient-friendly criteria and causes least disturbance in pregnant women's routine activity. But there are many studies which are against DIPSI. One of them is this by Mohan et al. Published in 2014. It was done. The screening was done in 1,031 pregnant women and WHO criteria, DIPSI criteria, and IDPSG criteria. All the three were used. And it was found that least number of patients were detected to have GDM with DIPSI criteria. So DIPSI criteria had very low sensitivity in this group, and this should be used with caution. Now, the Cochrane database says that there is no clear evidence to suggest which test is superior to screening for screening GDM. But the most important thing which is emphasized in all the studies is that even the mild GDM should be treated. This is another meta-analysis which shows the similar result, that is the mild GDM also if treated leads to a better maternal and perinatal outcome. Coming to the review on insulin analogs and the oral hypoglycemic agents, in this meta-analysis of 24 studies, it has shown that when aspartate, glargine and detamir, these were compared with insulin, they had the similar maternal and perinatal outcome in form of cesarean rate, birth weight, NICU admissions. In case of Lispro, it was found that they had higher birth weight in large for date babies. So to conclude, aspartate, glargine and detamir are safe for treating in GDM patients, but more RCTs are required. The most commonly used OHE is Metformin in GDM, and this is the landmark trial published in NEJM in 2008, which is a RCT in 751 patients, in which it was found that maternal and perinatal outcome were similar in the metformin and insulin group. But 46% of them required further insulin. That is the biggest problem. But most of them still preferred using metformin as a starting drug because it is an oral agent. When these patients, the offspring of these patients were followed for 2 years, it was found that children who were exposed to metformin had larger subcutaneous than the visceral fat. This is another study done in Pakistan by Ainuddin et al., which also shows that metformin is a very good alternative to insulin. And this is a study published in BMJ 2015, which also included glibenclamide. But the glibenclamide was clearly found to be inferior to both insulin and metformin, and metformin was equally performing in maternal and perinatal outcomes comparing to insulin. Coming to the second most commonly used OHA, the Glyburide, which is a very good alternative and has similar number of perinatal and maternal adverse outcome when the insulin is compared. But the most important problem is the failure rate, and most of them will require insulin. This is the meta-analysis which compares Glyburide with metformin. It includes 3 studies, and it found metformin to be slightly superior. And similarly, in this another meta-analysis published in 2015, it showed that Glyburide comparing to metformin is associated with increased risk of neonatal hypoglycemia, higher maternal weight gain, higher neonatal birth weight, and macrosomia. Now, this is a study which included acarbose as a therapy for GDM, and it found that more than 40% of patients required insulin later on in this group. But more studies, if done, maybe this can also be used in the GDM patient. Now, this is the AIMS experience. 2 studies have been done from the gynae department. One by Professor Nutan Agarwal et al., which showed comparing the Glyburide in the insulin group, that Glyburide was comparable to insulin in terms of maternal and neonatal outcome. And another RCT by Professor Neeta Singh et al., which compared the metformin and insulin, and it found that 16% of the women ultimately required insulin, but the neonatal and maternal outcomes were found to be similar. Now I would like to invite Professor J.B. Sharma sir to present the management part. Thank you.
So pointer either.
Okay. Okay. Thank you very much, Ipsita, and this for presenting the data. Okay. Pointer कहाँ है इसमें? So.
Yeah.
Okay. Okay. So many things have been covered already. It will be just a repetition. And Dr. Bala, good evening, sir. And, so GDM is any degree of glucose intolerance that either commences or is first diagnosed in pregnancy, as per ACOG opinion as well as WHO 1919, and the neuro terminology overt or gestational diabetes. So overt diabetes, all of us know, is a separate entity to GDM. And in our study, the overt cases were much lesser as compared to GDM. GDM is far more common, but overt diabetes definitely is much more dangerous, and there is a higher risk of adverse pregnancy outcome. But don't think that GDM is very, very benign, and all complications can happen in GDM. GDM patients can also need insulin, so we have to be careful about that. And then, yeah, so the various risk factors for GDM have already been covered, but advanced maternal age is important. And now these days the ladies are, for their career, they are getting married much late, they are obese and also that's why they are much higher risk of GDM. Multiparity is a risk factor. Obesity again is a big problem. Ethnicity, we Indians are at a higher risk, because we are fond of eating sweets and all. Physical inactivity, now physical activity has become much less, but thanks to Modi ji, the more yoga and all probably will put the patient right. And previous GDM or macrosomic infant is a much high risk factor. Polycystic ovarian syndrome, almost 30% girls are having PCOS, and all these are much more prone to develop diabetes later on in life. Then family history of diabetes, of course, is also important, and this should be taken. Now, the etiological classification is basically type 1 diabetes immune mediated, what we used to call IDDM in the past, or idiopathic. So these are the patients needing insulin. Type 2 diabetes, non-insulin dependent diabetes in the older classification. And then other specifications like genetic defects of beta cell function, genetic defects in insulin action, disease of the exocrine pancreas, endocrinopathies, drug or chemical induced diabetes, infections, especially involving pancreas, uncommon forms of immune mediated diabetes, other genetic syndromes sometimes associated with diabetes can be there. And of course, GDM is a separate entity altogether, type 4. So as per ADA and recently ADA 2016 again updated date. So we know that there are a lot of anti-insulin factors in pregnancy. There is only one insulin hormone, all others are anti-insulin factors. So HPL decreases insulin sensitivity, and HPL levels are, all of us know, increase significantly in pregnancy. Cortisol again levels are much higher in pregnancy. It promotes gluconeogenesis, so causing raised blood sugar level. Progesterone, increased progesterone levels are there, so that also increases gluconeogenesis. So placental insulinase again tend to deactivate insulin. Estradiol levels again, TNF, leptin levels are also increased. They also cause insulin resistant, and resistant adiponectin are also been found. So there is only one lion, insulin, and there are so many hyenas opposing it. So naturally, poor insulin gets, ultimately exhausted and diabetes happen. So diagnosis, basically we have already covered it, Ipsita and all, just to revise it, we have time. So diabetes in pregnancy diagnosis, more than one criteria are met. Okay, we have time, so I am just highlighting it again. So any fasting blood sugar more than 126 or equal to 126 also is per deciliter, or 2 hour blood sugar more than 200 milligram per deciliter, 75 gram glucose. So if you are giving 75 gram of glucose, so fasting more than 126 or equal, and postprandial 2 hours basically more than 200 are diabetics. Or any random blood sugar more than 200 or equal to 200 is also over diabetic. These are over diabetics patient than WHO 2030 criteria. And this is ADA. ADA is almost similar. Everything is similar. Fasting sugar more than 126 or 2 hour more than 200 with 75 gram glucose. These two criteria are similar. Only thing HbA1c is taken in this case. If it's more than or equal to 6.5%, then also we take a diagnosis of diabetes. And random blood sugar more than 2. These factors are also similar in the two. So any fasting more than 126 or postprandial more than 200 or random more than 200 or HbA1c more than 6.5%, then all of these are criteria of diagnosis. As far as screening is concerned, as already highlighted by my predecessors, so there are various guidelines. I won't repeat them, but I mean, nice guideline, National Institute of Clinical Excellence from UK, IADP, SG, as Ipsita covered, ADA, American Diabetic Association, probably the most respectable society in the world for this, American College of Obstetrics 2013, and DIPSI, Indian Society. But as he said, there are some problems with the DIPSI criteria. So ADA 2016 is one of the most respected, and all over the world people tend to follow it. No. And then so we have already covered that. So any, I mean, like in AIMS protocol, we are using either one criteria or two criteria, but any more than 126 fasting or more than 200 this thing is diabetic or in between. So these are the complications of gestational diabetes. I mean, so gestational diabetes can also same complication as over diabetes. Only thing in over diabetes, the complications like ketoacidosis, etc. are much more. So maternal complication can be preeclampsia seen in 10 to 20% cases with a relative risk of 1.7, premature labor in 20% cases, polyhydramnios in 5 to 30% cases. Stillbirth is always, I mean, you are always scared of stillbirth, sudden IUDs in case of diabetes as well as GDM. Operated delivery rate is 1.37 times. UTI and candidiasis are also common because of lot of sugar there. Recurrence in next pregnancy is as high as up to 50% in these patients. The long-term complications are again like GDM in next pregnancy. So if any patient who had GDM in the past is at a much higher risk of developing GDM in next pregnancy, and ultimately in 50% of these cases after 20 to 30 years will develop type 2 diabetes. So it makes sense that any patient who has GDM, we should counsel her that she should go regularly to Dr. Rajesh Khadgawat once a year if he can take up that load. So they should get their blood sugar tested every yearly. And ultimately, many of them will develop diabetes. So this is and this also gives an opportunity because her pancreas is just at the bottom. So she should take care. If she can take care of control of her diet, her weight and all, so she can actually prevent from going into full-fledged diabetes later on. So this is also, and then of course cardiovascular disease. Diabetes is a diabetes and goes with cardiovascular disease, and the two with increased sort of cholesterol. So they are at high risk of developing cardiovascular disease also. So this is extremely important that they should go for regular follow-up to endocrinologist or cardiologist, because ultimately many of them will develop ischemic heart disease and type 2 diabetes and of course GDM in the next pregnancy. And then in the fetal and neonatal, maybe Dr. Mace will tell us a little more about that. I mean, so macrosomia is a very common problem, 20 to 30%, and we all know it's because of Patterson's hypothesis. So more the blood sugar in the mother, more in the fetus, and the concept that fetus is not diabetic. So his insulin, his pancreas responds to that, and that's why insulin is a anabolic hormone, so everything fat get deposited. And then shoulder dystocia is a big problem. We should organomegaly, birth trauma, and then in neonatal complication, maybe Sir Dr. Mace will tell better, but they more want to hypoglycemia because this baby has been used to, fetus has been used to high blood sugar levels, so after birth they tend to go into hypoglycemia, so you need to feed them more often. Polycythemia, hypocalcemia, hyperbilirubinemia, respiratory distress syndrome, renal vein thrombosis, ventricular hypertrophy, cardiac failure, necrotizing enterocolitis, cerebral edema, and small left colon syndrome, electrolyte imbalances. All these complications are much more in the neonates. Maybe Dr. Mace can highlight a bit that. And ultimately, these offsprings have long-term risks also. Ultimately these babies are, because they've been their pancreas have been stimulated to that extent. So ultimately, these babies, when they grow up, they will become obese in later on in life, they will develop type 2 diabetes, they will develop cardiovascular disease, they may have impaired cognitive development, they may have impaired motor function, so their mental function may not be that good at other patients. So it makes, public sense also that, we should control diabetes so that our babies are, well off and they don't develop the disease later on in life and they are intelligent enough to become, other these complications. What happens? Sorry. Okay, and there is Professor Barker's hypothesis. If you have been heard Professor Barker's hypothesis, that the seeds of later on obesity and cardiovascular disease are shown in the fetus. So these basically mothers who are like gestation diabetes or mothers who have got IUGR babies, ultimately these babies when they grow up later on in life, they are more prone to develop diabetes, they are more prone to develop ischemic heart disease, hypercholesterolemia and all these problems. So it may, so at the time of, in fact, I heard Professor Barker's lecture actually he's from Southampton. He's written a book. So some lawyer rang him from USA that Professor Barker, my client wants to sue his mother because he developed ischemic heart disease at age of 35 years and he wants to sue his mother that you didn't look after me well in intertime life. So my mother was rich, So he said, are you willing to come to USA to give testimony? We send a ticket of Concorde for you. Concorde was supersonic aeroplane, very costly. So in future, be aware that if you don't take care of your fetus in utero, you may be sued after 20 years by your own baby, So, and these are the complication of over diabetes will be, of course, in obstetrics, any spontaneous abortion is much more common than congenital malformations, preeclampsia, polyhydramnios, preterm delivery, macrosomia, unexplained fetal death, IUGR, traumatic delivery. Usually, they develop macrosomia. IUGR will happen if they have diabetic vasculopathy. And medical, of course, retinopathy, it's an important cause of blindness. Nephropathy, ultimately these patients may end up in end-stage renal disease. Hypertension, almost 50% will develop, especially with vasculopathy. Hypoglycemia, infections, 80%. Neuropathy, gastropathy, diabetic ketoacidosis. So over diabetes are much higher risk of all these complications. So it's a very, very serious condition. And cardiovascular, in congenital malformations are usually seen in over diabetes, not in gestation diabetes. But as an obstetrician, don't say that if it's a GDM patient, don't say that your fetus cannot have malformations, because baseline 2 to 3% risk is there in all. So we can't say she can't have it, but the chances are lesser. But definitely in case of our full-fledged over diabetes, the congenital malformations are much higher. And these are cardiovascular, one of the commonest, ventricular septal defect, ASD, TGA, coarctation of hepatitis inversus. CNS are very common, acrania, anencephaly, NTD, microcephaly, holoprosencephaly, and hemivertebra. Caudal ligation syndrome is the most specific. If any fetus has got caudal ligation syndrome, so you can diagnose diabetes in the mother, over diabetes in the mother, but the chances of caudal ligation syndrome is so rare that most obstetricians die without seeing any case, in life. So, but if it is there, then it is almost certain. Renal agenesis, ureter duplication, cystic kidney hydronephrosis are renal anomalies, and duodenal atresia, incorporate and small left colon syndrome are the other complications. And for that, basically, we have to do. So, as far as the management is concerned, pre-conception care is extremely important. If you know of any of your relative who is diabetic, basically over diabetes, so you tell her that she should seek us, Dr. Rajesh Khadgawat and baby cardiologist before she ventures for pregnancy. So, because what has been seen that, the treatment starts 3 to 6 months before conception. Unfortunately, our patients are coming to us at when they are only 12 weeks or 14 weeks pregnant with over diabetes and with hemoglobin A1C of 9. So then the chance, I have seen 10 or 11 also. So that, then what can you do for the patient? So they should come before us that, doctor, I am having diabetes, over diabetes, my father, mother are there, so please help me. So then we can maintain euglycemia in the periconception period, put her on high dose of folic acid therapy, 400 microgram per day. And this is extremely important. Normally a diabetic patient doesn't have to be that mad about maintaining blood sugar all 24 hours, but these patients have to be mad because then only you can maintain the euglycemia and a normal outcome for them. And congenital anomalies, obstetric, fetal and neonatal complications, we have to tell them. Contraception until euglycemic. So till that time, glycemia is not well controlled, we should give her adequate contraception so that she doesn't conceive with high glucose level, doesn't develop malformation and others. And aim is to keep fasting blood sugar between 70 to 100, 1 hour less than 140, 2 hours less than 120. And HbA1c should be kept less than 7% and 24-hour urine protein should be normal for them. So if they have followed our pre-conceptional care, now she is pregnant and she comes to us. So in first trimester, we confirm the viability of pregnancy and gestation at about 7 to 9 weeks of pregnancy. So they should be seen at the earliest whenever they miss the period. We do HbA1c level because HbA1c will tell us about last 6 weeks maintenance. Blood sugar will tell us of only 24 hours, but HbA1c, so we can know that in periconceptional period this lady had a adequate blood sugar levels, and so she will have less chance of complication. If HbA1c at 6 to 7 weeks are say 9 or so, then there are very high risk of her developing congenital malformation. Then we need to do biochemical screening at 11 weeks with the dual screen, and later on we can do triple screen also for them. And ultrasound is done at 12 weeks, and anti-NBH scan should be done at 12 weeks. And this scan is also important. Look for anencaply, because these are the fetuses which sometimes there can be anencaply in them. So you can diagnose anencaply at 11 to 12 weeks of gestation, and we can do termination of pregnancy in first trimester rather than second trimester in that case. Then baseline renal function test, fundus examination, 24-hour renal albumin, it should be done every trimester, and especially over diabetes. In second trimester, then we do triple screen. Level 2 ultrasound should be done between 18 to 20 weeks. 18 to 20, because if you find any anomaly, then we can do termination of pregnancy by law before 20 weeks of gestation. But unfortunately, this fetal echo may miss the diagnosis before 20 weeks of gestation. So you need to repeat a fetal echo at between 20. Try to do at 20 weeks, but at 24 weeks we may have to repeat, because sometimes it can be missed at 18 to 20 weeks of gestation. Fetal echo, if you send the patients here, they don't do our cardiologists because they are too much mandated. So for gestation diabetes, they are not doing it. But for over diabetes, they are doing it. So at least in over diabetes we should do it, and we should do the 28 weeks scan for growth and Likert volume. In fact, 4 weekly scan is recommended for fetal growth, fetal well-being, Likert volume, and other complications in all patients of diabetes. And in third trimester, serial ultrasound every 4 weeks, like already said. And then non-stress test and biophysical profile should also be done weekly for them. And then when the patient, so mainstay of treatment is ultimately diet, exercise, insulin. So euglycemia has to be maintained, and routine is that initially we start with the diet and exercise, and we repeat the blood sugar after 2 weeks. If still post-fasting, post-meal, post-meals are high, if it is controlled with diet only and exercise only, the patient doesn't need any OHA or insulin. In that case, we can take the patient till 40 weeks of gestation, not a problem. But if the patient is not controlled, or more than 50% values are elevated, or hemoglobin A1C is, fetal AC abdominal surface is more than 75 percentile, then we need to give pharmacological therapy. Either insulin therapy is the traditional standard treatment. The OHA and all, as highlighted by our AIMS study by Dr. Nutan, Dr. Nita Singh, and by Dr. Venus, various studies, OHAs have been given, especially Metformin and Glyburide, have been shown to have good results. But and in these patients, any patient, so for the postgraduate should be very clear that induction of labor has to be done at 38 weeks for all patients of diabetes, whether they are gestational or overt, at 38 weeks, especially if they are not controlled on diet, or any pharmacotherapy or insulin has been given to them. And the glycemic goal is the main aim basically. So we need to keep a preprandial blood sugar of less than 95 mg per deciliter. 1 hour post meal is less than 140 mg per deciliter, the aim, and 2 hour post meal should be less than 120 mg per deciliter. And any pre-existing type 1 or type 2 diabetes, pre-meal, bedtime, overnight glucose should be, good afternoon madam, welcome, between 60 to 99 mg per deciliter, and peak postprandial glucose should be between 100 to 129 mg per deciliter, and A1C should be around 6%. A1C is the one of the best parameters. In England, they used to do fructosamine also, but I don't know, that is, Dr. Rajesh might tell, fructosamine is not very commonly done in India. So A1C is a very important parameter. So these are the, we should try to get them. Next please. And the lifestyle intervention, basically the cornerstone of treatment for GDM is medical nutrition therapy, dietary changes, meal planning, increased physical activity. So BMI based on weight before pregnancy is less than 19 kg per meter square, then the calorie intake should be 35 kg per kg body weight, and between 19 to 27 should be 30, and more than 27 should be 25. So as more the weight, then lesser the calorie intake should be done. And in a diabetic diet should contain carbohydrate about 55%, protein 20%, and fats 25%, and they should be less than 10% saturated fat, and they should have 3 major and 3 minor meals. So instead of having 3 major meals, they should have 3 minor meals also, so that the blood sugar levels are not to go too high. Okay, and the pharmacotherapy, insulin therapy, the standard traditional management, are still accepted anyway. OHA, etc., they are still experimental. So basal insulin is designed to restrain basically hepatic glucose production between meals and in the fasting state. Prandial insulin reduces glucose excursion associated with feeding. Total dose of insulin is 0.7 to 0.8 unit per kg per day in first trimester, 0.8 to 1 unit per kg per day in second trimester, and 0.9 to 1.2 unit per kg per day in third trimester. It increases. The requirement increases as pregnancy advances, but decreases after in puerperium. So calculated total dose, usually we give 2/3 of the total dose in the morning, 1/3 in the evening, and in the morning we have to give them both type of insulin, so that 2/3 of isopen and 1/3 actrapid. So actrapid will give immediate relief of the blood sugar, while isopen will be intermediate and long acting, so that will take care of the next 12 hours. And similarly in the evening again we give half of isopen and half of actrapid. So actrapid will take care of next 2 to 4 hours, while isopen will take care of the next 8 to 12 hours. So by morning the blood sugar will be maintained in 2 level. So we'll be lucky if the patient can be maintained with only 2 doses. Usually they need 3 or 4 types of doses. Maybe Dr. Rajesh can tell better. And why OHA needed in GDM compared to insulin based OHA have lower cost, no need for self injection, and lower hypoglycemia risk, 1 to 5%. Women on insulin have a 70% risk at some point of their pregnancy. But still, let me tell you, OHA is still experimental in pregnancy. I mean, traditional management has been insulin only. But given a choice, I mean, anyone, if I were to be given a choice, I will opt for medicine, oral tablet rather than insulin injection. A suitable OHA should possess the following factors: adequate glycemic control, lesser metal hyperglycemia, no placental transfer, no risk of teratogenicity, no long-term consequences, implication in labor. So it is ideal. So just like there is no ideal husband or wife, there is no ideal OHA also. But they are Glyburide is nearly like 70-80% ideal. So it's a second generation sulfonylurea insulin secretagogue. It's a category FB drug, so it can be given safely in pregnancy. Lesser placental transfer. 70% of metal levels found in fetal circulation. Alternative to insulin therapy. Onset of action is 3 hours. Duration is 8 hours. Main side effects are dose-related hypoglycemia. So hypoglycemia can occur with any OHA or insulin for that matter. We start with the low dose of 2.5 mg per day, then 5 mg, and maximum dose you can go up to 20 mg per day. If you are reaching that dose, probably the lady needs insulin. And OHA metformin basically is a biogonide, again category B, can be safely given. It's an insulin sensitizer. Crosses the placental barrier, reduces gluconeogenesis, increases intestinal absorption of glucose, decrease FFA, free fatty acid oxidation, TG, LDL, increase HDL. So it has lipid fat friendly, weight reduction, no hypoglycemic episode. So that is the advantage of metformin. Hypoglycemia is exceedingly rare, doesn't stimulate fetal pancreas. Starting dose is 500 mg to 800 mg per day. You can go up to 2.5 gram per day. But if the lady is needing more than 1000 mg, probably she needs insulin. And doesn't adversely affect breastfeeding, so it's absolutely safe to give it during pregnancy. Next, this is the safety of insulin basically. So insulin, again, we should use the traditional insulin. They are category B, lispro-aspartate and all. But this glycine etc. they are category C. Similarly, like the traditional Glyburide is category B in secretagogues, and metformin is category B. Other drugs, sitagliptin, maybe, these drugs, they are newer drugs. So, avoid using like newer drugs for which we don't have long-term follow-up of the fetus and all. So, but they can be, but the recent studies are showing that they are unlikely to cause fetal exposure, but some of them are category C. So, I will advise that if you have to use Glyburide and metformin only, for which we have studies available, rather than newer drugs. Timing and mode of delivery, again, I told that if the patient, normally we induce them, all patients of GDM for exams, PG student can say that at 38 weeks of gestation. Why at 38? Because certain IUD can happen in them after that. It can happen before 38 weeks also, but then the fetal is premature and they tend to have more RDS because their surfactant levels are poorer. But if the GDM is well controlled on diet, mind it, not OHA or anything, we can sometimes let the patient go up to 40 plus, maximum 40 weeks. So 40 weeks we have to induce them, don't let them go post date. And elective cesarean section only if fetal weight is more than 4.5 kg or any strict obstetric indication like placenta previa, etc. And interpartum management, usual dose of intermediate insulin is given at bedtime, withhold morning dose of insulin. This fasting blood sugar, electrolytes, urine sugar ketone done. IV infusion is vegan with normal saline. Don't start dextrose. And elective cesarean section in the early morning hours is preferred. Once active labor starts, but blood sugar is less than 70, then you can start. Instead of normal saline, you can start 5% dextrose. If the blood sugar levels are less than 70, but the levels are 100 to 125, then you can continue. Our aim is to get between 100 to 125 mg per deciliter, but don't let them go into hypoglycemia also. Blood sugar should be checked hourly using glucometer and maintain blood sugar between blood glucose at 100 mg per deciliter. Insulin infusion is started in another IV line, so 2 IV lines are kept there. And we used to use sliding scale in past, but now we are using insulin infusion. So usually less than 100 mg no insulin, 100 to 140 1 unit per hour, and 140 to 180 1.5 unit, 180 to more than that 2 unit per hour or mil per hour. And the postpartum management, so it's not an indication of cesarean section only for strict obstetric indications, and similarly no indication of forceps delivery, but beware of shoulder dystocia sometimes in them. And postpartum is basically insulin requirement reduced. Yeah, this is important. Just after delivery, insulin requirement reduced to half to 1/3. So they tend to go into hypoglycemia. So reduce the dose after consultation with the endocrinologist or otherwise, or maintaining the blood sugar level. And GTT should be done with 75 glucose about 3 months after delivery, because to pick up whether the patient is developing over diabetes. And fasting blood sugar at 6 to 12 weeks postpartum, and A1C also to be done at 6 to 12. So we need to follow these patients. I mean, after that, and then at every 3 yearly it's recommended, so that some of these patients can go into diabetes or cardiac disease, so that can be known. And the contraception, basically this is extremely important. They need contraception more, so you should be careful that all copper devices are absolutely safe. Category 1 for all types of diabetes. LNG is category 2, can also be used. Barrier absolutely safe, sterilization is absolutely safe. But in high risk cases with special indication. But all the more, these are the patients who need sterilization, but under precaution. Only thing, POP can also be used in all cases. Only thing in case of complicated diabetes like nephropathy, neuropathy, retinopathy, and other vascular disease, then OC pills, combined pills should not be given, category 3 and 4 drugs. But in the GDM again, GDM COC can be used. DGM is not a contraindication at all. And this thing. And diabetic ketoacidosis, I won't go into detail. The management is just like in non-pregnant state. It can be seen not in GDM normally, in case of over diabetes. And we know that when the bicarbonate level become low, blood sugar levels are sometimes 250, 300 or so, more than that in them. And then they have ketone bodies also. So we need to do basically arterial blood gases in them, in electrolytes and all, and start them high dose of insulin, loading dose 0.2 to 0.4 unit per kg, then maintained with 2 to 10 units per hour. And fluid isotonic sodium chloride is given, and high dose, we need to give them fluid because they are ketotic. And then later on, when the blood sugar reaches 250, so we need to start them DNS. So some glucose is also needed for them, and we need to give them potassium, and we need to give them bicarbonate because they are ketotic. And then this management can be done in collaboration with the diabetologist or with the medical person. And so to conclude, pre-calculation care is extremely important. If you know any of your diabetic relative, please tell her to visit the doctor before she ventures for pregnancy. And euglycemic state should be achieved before conception, during first trimester, second, third, and periconception. I mean during labor. Diet, exercise are important goals of therapy. Maternal perinatal outcome can be improved by maintaining euglycemic control throughout pregnancy. Biophysical profile is important if it is monitoring. Cesarean section only for macrosomia and obstetric indication, not for that. And yeah, so that, thank you very much. So these are some diabetic babies. They tend to be very plump and all. They look very lovely, but please, I mean, the mother should be beware. I had a mother, she said, "Doctor, my son has become very weak." And I got so annoyed, the baby was very fat. I said, "He looked like a baby rhino to me." She said, "Doctor, you haven't seen him before. He was a baby elephant before, so he has become weak." So no, we shouldn't have this mother that never scold her child. No, I mean, then we are harming our own children. Okay, so, but what I've seen, like in John Radcliffe Hospital, London, John Radcliffe Hospital, Oxford, and King's College, London, the outcome of diabetic pregnancy is the same as the non-pregnant lady, because they maintain absolute euglycemia in the periconceptional period and throughout pregnancy. And their chance of occasional IUD has happened, but the statistics they have been presented by King's College London and John Radcliffe Oxford, and their outcome of diabetic pregnancy is similar as non-pregnant state. So by maintaining euglycemia throughout pregnancy, you can maintain the outcome to a near normal state. So that is a distant aim. For we in Delhi, in India, because our patient reached to us only at 12 exercises. So now I request Dr. Mesh Agrawal to tell a little bit about the neonatal aspects. Acha.
Yes, sir.
Okay. So just sorry.
No, I think it was a wonderful review, and I don't have much to add. Just want to tell you the AIMS data. So you just presented one unit data, but if you look at all the 3 units data in last 3 years, we had an incidence of GDM of something like 12.6%. So I think this is one of the most important indication of booking at AIMS. And the complications that you have mentioned, but the major problem that we face is that of hypoglycemia, and therefore we need to really focus on the early feeding, make sure that there is no feeding deficiency, and the screening. And if there is any hypoglycemia, then of course we need to treat them with oral feeding and sometimes glucose also. One thing that I wanted to make is that, particularly for the residents, that these babies tend to have a typical phenotype, macrosomia. So these babies are not enlarged overall. So you will find that there is more adiposity, but the more adiposity around the chest and around the shoulder. So therefore, that's the reason that they tend to have shoulder dystocia. Though, I mean, the data that you presented, that was just 3.5%, so not a major problem. Perhaps our obstetric colleagues do such a good job that we hardly have, except hypoglycemia, much of the problems. One other point that I wanted to make is that in the first year, what we see that these babies tend to have catch down of the growth. So they begin at 4 kg, but if you look at their weight gain in the first year, then that is lower than the babies that are normally born. So there is catch down, like in IGR babies, sometimes you have catch up growth. So these babies tend to have catch down growth. And then the issue of subsequent obesity and metabolic syndrome actually happens in later life, later childhood and adolescent, and they tend to become obese, and many of them tend to have diabetes also. I think that's all. Thank you.
May I get Dr. Rajesh Radhaut is there? And you can also ask questions from them about the individual aspects and as well as
So it's yours easier. Sir, you have extensively reviewed all aspects of gestational diabetes mellitus, so there is hardly anything to add. If I am adding anything, it will be just repetition of that. Just slight element of disagreement. What you have presented is one use of oral hypoglycemic agent. We are still very conservative. We more rely on insulin because the data with the use of Glyburide is not that strong to be used in clinical practice. None of the major professional bodies has recommended use of Glyburide in pregnancy. Still, they want to go with insulin. And insulin also, it's more conventional type of insulin rather than the recent analogs. Although there is some data on use of glargine, but because of his higher binding with the IGF-1 receptor, there is a higher chance of mitogenic potential, so has been contraindicated till now in the use in the pregnancy. Second little disagreement was you said that it's very difficult to maintain euglycemia. It's not very difficult to maintain euglycemia. 70 to 80% of GDM can be easily controlled with a diet and exercise. It's only 20% or 15 to 20% which requires, apart from lifestyle modification, requires some either metformin or insulin. We prefer insulin because our experience is based on our clinical practice, not based on studies. And one of the major problem with that major metformin trial was that 50% of them required insulin for control of blood glucose. So if we are likely to, if we are starting any treatment and 50% chance we are likely to shift to other, then insulin is time tested, it's safe, no mitogenic potential, and now there are studies are coming out that those mothers who have received metformin during pregnancy, their babies have more atypical distribution of fat rather than the normal babies. So these things may have long-term consequences, especially in terms of insulin resistance. Till more data is available about safety of the Glyburide or other oral hypoglycemic agent, we usually more rely on conventional type of insulin treatment. There was somewhere in the slide I've seen that there was HbA1c apart from first trimester. Usually HbA1c is not a very robust modality to assess glycemia because it will give you retrospective portion of glycemic status which is not of any importance in a diabetic patient. So most of the professional bodies do not use HbA1c. Fructosamine, yes, it has been started in clinical practice, but not very common. It's not available. It's available with a few commercial labs, but it's still not widely available in the clinical practice. Yeah. Thank you.
Thank you very much. I mean, I never said that, oral Glyburide and only thing there's some studies have been done and results are there. But actually in clinical practice, even we are still using insulin. That's the time test. I totally agree with you. And as Dr. Rajesh said that use the traditional insulin rather than newer ones because we don't have robust data about them and we know the safety of that. And we have Professor Sunesh Kumar sir, you want to make any comments? Yes, and then Dr.
I know these are bad manners to comment about your colleagues, But generally, grand round means that we have data of 200 patients and we compare with the previously published series, equally large or larger series, and see how is our data different from the previously published last series. It seems in last 1 hour we have repeated chapter of diabetes in pregnancy 3 times. You made a mention that there is no increase in risk of congenital malformation in GDM. It will be wrong to say that. Even in your series, you found that there were more congenital malformation in GDM group compared to over diabetes. And this is what we have been seeing. Even GDM have increased risk of malformation. We really don't know when, although we say risk of malformation gets determined at the time of organogenesis, but mostly we tend to detect abnormalities in glucose tolerance late, so we're not sure how bad it was at that time. And we have seen patients who are picked up GDM in second half of pregnancy, still there was a malformation in the babies. So we just cannot say that there is no increase in risk of malformation. There is a little difference in the pattern of malformation in 2 groups. Those who are long-standing diabetics are at a much greater risk of having the cardiac malformations, gross malformation, caudal regression syndrome, and others major malformation. But even in the GDM, there is an increased risk of malformation such as neural tube defects. So never ever have that feeling that they are not at an increased risk of malformation. Even if you have diagnosed late, do scanning again to rule it out. And this has become now a big problem, GDM. In fact, any patient is booked with you, you make all efforts to diagnose, and to our surprise, we find almost 1/4 of them have diabetes. But I must compliment, you have taken out good data, it is worth publication, but only after you have compared with the major published series.
Thank you, sir. Sorry for that. I think point well taken by sir. Okay, and I apologize for if any mistakes were there. And yeah, definitely, I mean, I'm not saying that, I just said that traditionally in MCQ they say, because this develops after like 12 weeks of pregnancy, so chances of malformation are not that high. But even in our data, I think the results were higher. And we have Professor Deepika Dekar, madam, you want to comment anything? Okay, she is fetal medicine expert. Anybody wants to make any comments, any queries, any PGs, any queries? Because we have Dr. Mace and Dr. Rajesh also. If any PGs, any queries about diabetes and all. And as sir said, we will follow. I mean, sir will compare the data with that and will write it accordingly. Then, otherwise, thank you very much everybody for coming and for this. Thank you. Dr. Lalwani, our registrar is there. So
I think everybody should be seated.
Okay,
We have a research presentation again from Department of Obs and Gynae and from Department of Transfusion Medicine.
Okay.
So I think first we'll be starting with the Department of Obs and Gynae, Dr. Deepika Dekar and Dr. Sujata Mohanty. Both are going to share their views on research conducted by the Department of Obs and Gynae.
Sujata, आ गई क्या? Sujata? Sujata? Sit in front. हाँ.
First हम डाल सकते हैं
सामने बैठिए. हाँ, वो कॉलर माइक है क्या? पूरा वो कर लिया ना? If you have a collar mic, है? यहाँ से कर. और इधर का ले.
वो कैच करेगा मैम, आप रूम पे बोल सकते हैं.
ओके.
पावर माइक
थोड़ा सा आगे ले. पॉइंटर.
हाँ, पॉइंटर.
किधर करना है? इसके ये वाला लाइट ऑफ कर.
हाँ, बंद कर लो.
Shall we start? So it's good evening. So it's nice to see that in a faculty presentation we have house semi-full. So we are going to be presenting something quite different from obstetrics and gynae. And this is a research project which was 2014-15. And it's about stem cells, how we can actually find a new source of stem cells. तुम्हारा वाला ले आओ लैपटॉप रिफ्रेश करो रिफ्रेश एक्चुअली फोल्डर को फोल्डर नहीं लिया इसने सिर्फ लिया वीडियो नहीं आएगा
इसमें नहीं आ रहा
फोल्डर को लिया था ना पेस्ट पेन से लगा आपने करना ही नहीं पूरा फोल्डर करना चाहिए ना उसको पूरा फोल्डर उसको कंटिन्यू करना कंटिन्यू फोल्डर करना
And till it opens, you can tell us something about it. Like, till they open.
Or we can ask the Department of Transfusion Medicine to start and we can you can start. I think meantime they can start.
Yeah, he's just giving the cable. Jaldi laiye, please. Just give 2 minutes. इसको करो वीडियो से कर लिया ये आ गया वो खोल दो ये वाला आ गया इधर से खोल जी हाँ आप नॉर्मल वाला लगाओ इसको कनेक्ट करो
इसको करता
Okay, we are ready to start. I hope video will come. So what we are going to talk about is amniotic fluid as a source of